So we're going to talk about cholesterol and the lipids. It's going to be interesting. Man, that's going to send me into retirement. For the next 20 years, I'm going to be talking to people about cholesterol. Oh, gosh. Recently, someone drove down from Northern Virginia to just talk about cholesterol. Anyway, hope everything's going well. And it was my pleasure to meet people not only in the clinic, but I met people on the low-carb cruise and all these other places. When we did Adapt events, it was fun to meet you all out in the real world. But as someone recently came to the clinic, really, she just wanted to know that I was real. Like, not just some YouTube thing. And then Glenn tells me, Glenn Finkel, my business partner, and he showed me that there is now a service where you can send, type in your information, and it's going to come back in my exact voice. So it's basically AI for voice. So you're never going to know if it's really me anymore. Although I have to say that the first voice overs that came back, the computer was just a little too forceful, I thought. So I don't know. I don't know if you can tone it down a little bit, but it's pretty amazing how close that computer can replicate my voice or anyone's voice for that matter. But so back to something a little more mundane. Cholesterol, of course, is necessary for life. I learned in writing the ALA cholesterol course. Did anyone take the course? Just raise your hand with your grade or even your reactions. Raise hand might be one way. Yeah, so a few of you took the course. I learned that if you're born without the cholesterol pathway, making the ability to make cholesterol, it's baby can't survive. So without the ability to make cholesterol, the fetus aborts. It's that essential to life. So how it became thought of as a bad thing is kind of while it taught like it's truth, it really is not the whole picture. That's my diplomatic way of saying that what we were all taught about cholesterol. And if you ask doctors today, what does LDL cholesterol do? They'll say, well, it causes heart disease. No, that's all they're taught. So actually, if the spoiler alert, the whole cholesterol class can be condensed into, you need cholesterol. Cholesterol is not bad. And, you really don't need a statin or to lower the cholesterol level or anti-inflammatory effect of the statin. They don't quite know why it works. You wouldn't take that unless you had a history of arterial disease, a stroke or heart attack or some evidence that you had the disease, because the primary prevention, meaning you're taking a pill and you don't have the disease yet, it doesn't really do much of using a statin drug. So you can go to the statin decision aid tool, and maybe we'll do that later with your information. At the Mayo Clinic website, they actually have a tool you can put in your information and then get your risk calculation, and then the calculation of your risk if you take a medication, so you can see how that changes. But so I'm not, totally anti-statins by any means. If I was, I would be way out of the mainstream and perceived negatively by my peers. And as someone in one of the YouTubes I did, someone commented, you're scared of what other doctors think. And I wrote back, yeah, I am. I care about what other doctors think, because generally we're, a scientific group of people, and if I'm way out on the limb, I'll get kicked out of my university. So while some people are not in a university setting, they're not even in a private practice with a group, they're just lone wolves on their own. They can say whatever they want without recrimination. And so if I'm way outside, so far outside what the mainstream thinks, that's not good for me. And I think there is a role for using medications, although I think they're overused. But so anyway, cholesterol is necessary. So when someone comes in now and says, well, my cholesterol went up, I say, good, and just wait for the response. And I know most other doctors don't say that, but the first time I was introduced to this whole diet, two of my patients did it in front of me. I didn't tell them to. I was at the VA hospital here in Durham, North Carolina. And when I asked one of the gentlemen what he did, he said, all I did is eat steak and eggs, for shock value. And the concern was the cholesterol would go up. And so that patient came back again, and I said, the concern is your cholesterol is going to go up. And he looked at me, this far away from me, and said, well, why don't you check it? Okay, it didn't cost anything. It was the VA. The lab was down the hall. And so 2 in a row that people did this way of eating, changing from eating carbs to not eating carbs, and 2 in a row, the cholesterol levels looked better any way you looked at it. The total, the LDL, the triglyceride, the HDL. So, now I know that the odds were in the favor, but had I had a bad odds, bad roll of the dice, I wouldn't have studied this, because so 2/3 of the time now, pretty much across the board, how you look at the cholesterol levels, it'll look better. But 1/3 of the time, it won't if you look at it in the old way. So there's an old way and a new way. And what's ironic is the old way is what everyone thinks and all. The new way has actually been around since the 1980s and was just kind of suppressed or marginalized from the medical world, called the metabolic syndrome. And part of the issue was there was no drug to treat the metabolic syndrome. It's a constellation of things, although an internist basically, as I was trained, will give a pill for one component of the metabolic syndrome, the blood pressure. They'll give a pill or a shot or multiple pills for the high blood pressure, give a pill or a shot for the blood glucose elevation, the diabetes part of metabolic syndrome. They pretty much ignore the abdominal circumference elevation, the obesity side of things, although now every doctor is a weight loss expert with the semaglutide that's in pills and shots. And it's a little concerning because people aren't taught what to eat and they have their appetite suppressed. So many people are losing weight too fast. But so anyway, we train doctors to treat each component of the metabolic syndrome out here with drugs. You treat the root cause and all of these things will get better. However, the triglyceride and HDL almost always gets better. Triglyceride coming down, HDL going up, and that's the component of the metabolic syndrome in the blood. So metabolic syndrome, looking at the blood, doesn't include the total cholesterol and LDL. So it's not even, it's like we're speaking a different language. I guess it would be like when let me know if any of you are experts in cars and automobiles, what happened when I understand there are rotary engines and there are other types of engines. What did the old engine people say? Those don't work. They can't do it. Well, no, it just works differently. But the knowledge about metabolic syndrome is kind of spotty, few and far between. And just about every doctor focuses on the total cholesterol and the LDL cholesterol. That's just the reality that we're in. Now, if your triglyceride goes down, your HDL goes up, I don't really care what happens to your LDL and your total, but I know other doctors out there will focus on the total and the LDL. If you looked at the type of LDL, there's that kind of advanced particle, NMR lipoprofile it's called, or the VAP test. You can actually know if you have large LDL particles or small LDL particles. But in probably the best study to date about risk prediction using these tests in the blood, it wasn't the total in the LDL or the particle size or particle number of the LDLs. It was the summary score called the LPIR score that was the best predictor, which summarized all the metabolic syndrome components So the best way I can think about it, just explaining, is that there's a different mechanism of reducing cardiometabolic risk. Like there are different kinds of phones, different kinds of cars, and at different types. And if doctors are only trained in one way, that's, you just have to understand that doctors are trained to look at the LDL, not even the particle size. The guidelines kind of dumb it down to, if the LDL's high, just put people on a pill or now a shot. But the cholesterol is not a disease. So that's probably one of the big take-home points. So you need cholesterol, and an elevated cholesterol is not a disease. It's a predictor, and it's not a great predictor even by itself. So what you're trying to do is prevent or the starting or the continuation of atherosclerosis, which is a process that affects the arteries, not the veins, the arteries. And so cholesterol is not a disease. But what's happened is it's easier to measure the blood. So they've made the guidelines say, just let's check the blood, and because these drugs are so inexpensive and they make money for so many companies now, that let's just lower cholesterol. And so smart people got in rooms and said, well, yeah, there's a correlation somewhat between cholesterol levels and heart disease and stroke. And if you put people on medicines, there's a small reduction in those things. So, we won't even assess if you have arterial disease. We'll just put you on a pill based on your cholesterol level. So there's a tension between guidelines, one size fits all sorts of things, or sticking up for an individual, the individual health, the care of the patient in front of me. And that's my perspective. I was always trained, how do I take care of you who's in front of me, rather than how do we put all this information into a guideline so that we can have, not well trained, or how should I say, less years in training, just tell people to check if cholesterol and give a pill. So if I'm going to give you a medicine to prevent atherosclerosis, I want to know if you have atherosclerosis. So think about it. If you're given a medicine based on your cholesterol level, the doctor, I'm just say doctor, but I know it's healthcare professional, healthcare provider, the nurse practitioner, PAs. I don't need to demean anybody, but so the healthcare professional is giving you a drug, a pill, without knowing if you have the disease. Can you imagine if you got chemotherapy for cancer and they didn't know if you had cancer or not? No, you can't imagine that. In fact, the cancer practitioners were always the ones in training. As I recall, when I was in training, they said, we need tissue. We need tissue. We need a biopsy. We need evidence that there is cancer. And if it's not definitive, they'll do another biopsy. They'll get tissue and then give a treatment. Now, you might say, well, everyone gets atherosclerosis. That's not true. It's a overgeneralization. Or you could say, well, a statin drug or these other medicines have no risk, so it's not like chemotherapy where you have toxicities and all that. Well, they're not risk-free, these medications. And I, don't practice with a whole lot of doctors, but even in my small sphere of other doctors, the one case popped up already where someone was bedridden, and it turned out that it was the statin medicine doing it, but nobody suspected it. So it took someone who was outside, probably older, teaching doctor kind of thing, who kind of said, well, let's stop all the medicines and see if this person gets better. And, no one suspected, even though myopathy and muscle issues and memory issues are, high on the list of statin side effects. In practical reality, most people don't question whether it's the cause of a side effect or not. And so I've fallen out of the world that assumes medications can do no wrong. And now I suspect a medication might do anything. So ask your doctor, well, why are you giving me that pill? It's for your cholesterol level. And you say, well, is cholesterol a disease? well, the guidelines say you press your doctor on this, Well, but what is cholesterol doing anyway? I mean, well, it causes heart disease. And then you say, well, do I have heart disease? Well, everyone has. No. In my family, my cousins, my parents, nobody had heart disease. When I think about it, my family history was cancer. When I looked around, and while my parents didn't have autopsies or anything, but they didn't have any overt issues. Lived to their 80s and 90s, so you can kind of get an inkling of whether something runs in your family, and so now you could even say something like, "Well, would you give me medicine for cancer if you didn't know I had it?" Well, of course not. I wouldn't give you medicine for cancer. Well, why are you giving medicine to prevent heart disease when I might not even have it? So you might say, well, you're going to get it one day. Well, so if you're 63 years old, like me, and you haven't developed heart disease yet, would you want to take a pill that is going to prevent your risk of getting heart disease that you don't have? So that was the aha moment for me when a family member or a cousin was told to do a low-carb diet, a low-fat diet after being hospitalized. He didn't have heart disease. Thought he did. They thought he did, but it turned out they did a heart catheterization and there were normal coronary arteries, no heart disease. But as he left the hospital, the dietitian said, well, we want you to do that low-fat diet because it prevents heart disease that he didn't have. Oh, no, this makes no sense. So use your common sense is neither common nor sensical to a lot of people, but the same sort of questioning that you would do. Well, doctor, would you put me on a chemotherapy if you weren't sure I had cancer? Well, so doctors really are trained to know how to assess you for having heart disease. They've all been taught to use the cholesterol as the proxy or the intermediate or the correlative sort of measure, and it's not a great correlation measure. So you'll have to ask, well, so actually I talk about getting your own arteries measured. So remember, cholesterol, even high cholesterol, if it's causing a problem, it's going to be causing arterial vascular disease, not venous, it's arterial. And so what you want to do is get your carotid, which is your neck arteries, and your aorta, which is your abdominal artery, measured. Well, how do I do that? Well, it's called an ultrasound that's been used for decades in the obstetrics offices. It's, they do it on babies and fetuses to see as the baby grows. When it's used on the heart, it's called an echocardiogram. Changed the name there, but it's still ultrasound technology. So it's sonar. It's thought to be harmless for using on a human. So best I can tell, in my area and what people tell me, doctors aren't readily convinced to get a test for this unless you have a symptom. So they're not going to be into the prevention side of assessing things. But, if you had a house and the bank was going to give you a loan for the house, you got to get an inspection, and they don't just kind of look at a distance and, oh, well, no, it sounds good. They go in and inspect your house. So you want to know to the degree that it's easily obtained and safe, whether you have vascular disease. There's a company that goes around called Lifeline Screening, www.lifelinescreening.com, and they'll come to your area and they put up their equipment in an area in town. Might be a fellowship or a church, synagogue. Locally in Durham, they have sort of there's a technology area, swing space, just open rooms that people rent. And so you go in, you get your ultrasounds done, and they send you a report. So you can know if you have atherosclerosis or not. They'll tell you on this report. Now, I got into talking about this, and it's not really in any medical guideline because, can you imagine if everyone asked for a preventive measure, test of, doctor, I want to know if I have artery disease. Okay, well, so there wouldn't be enough ultrasounds in the medical system, and people are charged so much for the ultrasounds, or insurance is charged, that the system would break. So you have to kind of take that into your own hands. Go beyond the assumption that high cholesterol means a disease. It's not. And what you're trying to do is prevent the arterial disease. So even if you're a lean mass hyperresponder, your LDL is super high, 350 or whatever, get a measurement to see if you have arterial disease. The ultrasound I talk about first. And no, it's not testing the heart directly, but because it has no risk really at all, there's no radiation, there's no interaction with the health system, because these ultrasound machines company will come around and do it without a doctor's order. I talk about this first, so you can get an idea if your body has been affected by atherosclerosis or arterial sclerosis, the same process, or if you have narrowing of the arteries. You wouldn't want to be put on a pill to prevent narrowing of the arteries if you didn't have it, regardless of what your cholesterol level is. And you can do these tests periodically to see if you're developing it. So I got into this and started talking about it because people would come back to me saying, well, I'm on the keto diet that you recommended. Well, okay, I didn't make it up. And after 2 days, everyone goes into ketosis if you don't eat, but it's got to be bad for you. I'm starting to introduce into language when I speak that, would a computer say, a low battery, I'm going to go into self-destruct mode. No, if you're in a low energy situation, things that, we create like computers or phones, we say, let's go into an energy conservation mode. What kind of organism would start to self-destruct if there wasn't energy around, if you weren't eating anything? I think actually this, to me, suggests that nutritional ketosis has advantages to help you, to protect you when there isn't food around. But that's a conjecture. But so people started saying, well, is this risky? What about the long term? Well, we have no long-term studies. There are no long-term studies. In fact, there aren't great long-term studies of any diet, let alone weight loss, let alone vascular disease. So how do we measure something to know if something's changing? You get the ultrasound, you get the CAT scan of the heart. That's the next. It's called the coronary artery calcium score, or capital CAC, capital C, capital A, capital C score. It's a CAT scan that looks directly at the heart, whether there's any calcification. And so if you follow these tests over time, you can see if whatever you're doing is causing some sort of, vascular problem. So cholesterol itself is not a disease. In fact, you need cholesterol. Every cell needs cholesterol. If you're born without the ability to make cholesterol, there's a genetic anomaly. The baby dies, doesn't grow. It's basically an aborted fetus. So it's so essential. You need cholesterol. And the idea that cholesterol in the blood predicts heart disease and stroke is not a strong correlation. And so you can actually measure to see if you have the vascular disease. Now, so the easy answer is, if you don't have vascular disease, your carotid, your aorta is clean, meaning they say it's normal, no evidence of any disease. You do a CAT scan of the heart, the coronary artery calcium score is 0, meaning so calcium comes into these arteries when the arteries heal some damaged area. So if you don't have any coronary artery calcium, then you don't have any plaque that has been built up that heals with the calcium. So the calcium score does not show you non-calcified plaque. It shows you areas where you've had healing. So it's not perfect either. But in large studies where they've done these coronary artery calcium scores in thousands of people, they're Americans who eat carbs with that, specific detail. If you have a coronary artery calcium score, the likelihood of you having a vascular problem, a stroke or a heart attack over the next 10 years is exceedingly low. So there's a group of papers now called The Power of Zero. If you go to PubMed.gov, which is our Medline repository of research articles on the power of zero, these articles will come up saying, if you have a coronary score of 0, the likelihood of you having a heart problem in the next 10 years is exceedingly low. So you don't have calcified disease. You don't have the disease. So in fact, now it's percolating into a few guidelines, not all of them, among cardiology's guidelines, actually, that if you have a coronary score of 0, there's no need for statin treatment. And this is like the going into a church and saying there is no God. I mean, it's not welcome among cardiologists to say, you don't need to treat the cholesterol, because that's what they've always been doing, and that's what they've been taught. It's what seems normal and comfortable, like driving on the right-hand side of the road. It would seem odd and uncomfortable for me if I started driving on the left-hand side of the road. In fact, doctors will introduce fear language and risk, and you have to do this, which really is not appropriate. I mean, a doctor is an advisor, not a thumbscrew pusher to make you do something like take a pill to reduce cholesterol. So now, if you do have vascular disease, well, that's a different issue, and there's a big gray area now where there are not studies of, now that we have this Pandora's box of calcium score. If you have a calcium score, but it's low, but it's not super high, no one really knows what happens when you use medication to treat, regardless of the cholesterol level with a medication. So that is a gray area. Some doctors are just kind of saying, well, you have calcium there, you have the disease, we'll put you on a pill. But what's more, I would say more solid is if you've had a stroke, you've had a heart attack, which basically represents you've had a problem that was serious enough in these arteries that it stopped the blood flow, and it made the heart have not enough oxygen, not enough blood flow. It may have damaged the heart or not, but it means you had a significant narrowing either in the coronary artery or the brain, leading to a stroke. That studies giving statin medication or other medicines and driving the LDL down to almost 0, it will reduce the events that someone has, and the problem with that is the event reduction is not super high. It doesn't eliminate it, but it does reduce it. And there, the persuasion and the marketing got the companies to start using relative risk reduction as opposed to absolute risk reduction. If you don't know what that means, it means basically if your risk went from 2% to 1%, the company could say it was a 50% risk reduction, not absolute. So 50% relative risk reduction is what they really meant. And so some people would respond and say, well, 98% of the time I wouldn't have a problem, and taking this pill, it reduces my chance of having it to 99% of the time, or increases my chance of not having it from 98 to 99. So is that worth taking a pill for 10 years or so? And, if you have side effects from pills, then, that's where, maybe even if you've had a heart attack or stroke, the side effects may outweigh the benefits. So there you get into a clinical, personal decision. And that is why I'm not anti-statin. At the beginning, I said the reason was it would put me outside the mainstream, Well, and now the detail is that, well, there are scientific studies, randomized trials. Yes, they're criticized as being, fraught with fraud and error, and they underrepresented. You have to go with the information that you have, and those kinds of conspiracy theories about the companies doing things, that may or may not be true. We have to make the best decision that we have. And so the science says, yes, there's a small reduction of recurrent stroke or heart disease with some kind of treatment of the cholesterol level, whether it's the cholesterol lowering or the anti-inflammatory effect of the pill that's doing it is an open question. Steve Phinney at a recent paper or presentation basically said they're looking at the data now with their Verta diabetes study, and the effect of the diet alone on inflammatory markers was stronger than medication treatment. So now let's enter in that a lifestyle change can be a potent intervention. And the idea that, okay, you have a problem like atherosclerosis or a cholesterol level that's high, you don't have to always first go to cholesterol reducing medication. You could do lifestyle change. So let's say you're in a discussion, well, your cholesterol's high. Well, doctor, I've just started the keto. No, doctor, I've just gone on the Mediterranean diet, a modified Mediterranean diet. And I'm going to treat my cholesterol by lifestyle. And I'm going to come back 50 pounds from now, lower. Then I want you to check my cholesterol. So you can barter, negotiate, buy for time, if you're just getting started. A little known fact, and it's Steve Phinney who pointed it out years ago, when you're losing weight, you're actually pinching off your cells, the fat cells, making them smaller so that cholesterol is getting liberated into the blood. And so you can have a temporary increase in your blood cholesterol based on losing weight. And it has nothing to do with the diet that you're on. And I saw that years ago in our first low-carb versus low-fat diet randomized trial. There were people on the low-fat diet whose cholesterol went up. Yeah, they were on a low-fat diet and their cholesterol went up. Now, do you ever hear about that in the news? No. So the fact that they were losing weight, I think, is the reason that the cholesterol went up. I didn't know it at the time. But so don't check the cholesterol while you're losing weight. It's my best recommendation. And if you end up, 2/3 of the time you roll the dice, the cholesterol is going to look better across the board. Total is going to come down, LDL comes down, triglycerides come down, HDL goes up, and HDL will keep going up over time. So that Dr. Atkins had a few things that I were just kind of planted in my head, and things he said was HDL just keeps going up. So the longer you stay away from carbs, your system is going to re-equilibrate, and HDL will keep going up. And so if you're one of the 1/3 who have the high LDL in total, the way I look at it is that's just the old way of looking at the blood. I want to know what the triglyceride and HDL does. And, 95 out of 100 times, the triglyceride goes down and the HDL goes up. So it's not 100%. So I've had people send me their labs and their triglyceride went up. I mean, not a lot, but so we give these generalizations, but an individual might have an elevation in triglyceride. But as long as the HDL is coming up and, you have no disease here, don't just stick your head in the sand. Keep measuring these things, keep measuring to see if you get the disease over time. And I'm happy to report that based on one individual who had the high LDL, Dave Feldman, he got a GoFundMe together to do a study on people who have really high LDL levels. And so if you're not familiar, or if you really want to go down a rabbit hole on this, the cholesterol code is Dave Feldman's website, and the Facebook group is called LMHR for Lean Mass Hyper Responder. If you have a high LDL, go join that Facebook group. You'll join other people, and many of them have had this for years, and you'll at least be in the community of people who are wondering and worrying, and yet it will reassure you that there are other people who have this. It's going to be hard without controlled and systematic research to know if this is something harmful. And so Dave has a study going on now where 100 people with high LDLs were flown out to LA to probably the world's best CT angiogram center. Now, CT angiogram is beyond the CAT scan score. It's not the CAC score. So the acronym is CCTA for Coronary CTangiogram. And Dave tells me that he bought his own coronary angiogram score. He wasn't in the study, but he asked them and they charged him a couple $1,000s for it, but he wanted to know. And so you can go some places and ask for it to pay it out of pocket, or you might be able to convince a doctor or a cardiologist to order it. But most will not feel comfortable doing it because, you don't have a high risk profile, or, nowadays some doctors are so afraid of that LDL elevation that you could use that to persuade them. Well, but I'm worried. Look how high. Normally they'll say I'll put you on a pill. That's easier. But if you could argue, well, I wouldn't buy a house unless they, inspected the pipes. My coronaries are nothing but pipes, and I want to know if they're blocked, if you can convince someone to order it for you. The coronary CT angiogram, the CCTA, in this study, you can actually see the inside of the artery. And, if you think about it, we sent people to the moon and we could see things miles and miles. It kind of makes sense you'd be able to see the inside of an artery. But, I guess the motion artifacts, the heart's pumping, you got to account for that. And so the study enrolled 100 people at baseline getting this coronary CT angiogram. Now that they're in the study, they're required to measure their ketones, write down what they're eating, measure their weight. They want to know that over the next year, they're in ketosis, keeping the carbs really low. Because the question of the study is what happens to people after a year of being on this diet and having high LDL levels. And so many of these people came in already knowing that they'd been on the low-carb diet with high LDLs for 3 to 5 years. And then the baseline data, while Dave Feldman hasn't published it, and even when he talked publicly about it, he didn't tell us the details of the results because they want to get that published first. It just helps with the credibility of things. But at baseline, he basically said not many people had disease, even though many of them had high LDLs for years. So, and 100 people is probably going to protect against the bias that what if you only did 5 people, what if they were all destined not to have heart disease anyway, regardless of what you did. Some families don't get heart disease, like mine. So you want to have enough people so that there isn't some random chance that you're going to just have bias and the study's really not detecting or measuring in the right people. Oh, I should give you the backstory that why a year or 3 years is important with this familial hyperlipidemia. That, careful, if a doctor says you have familial hyperlipidemia because your LDL is high now and you didn't have high LDL before, you don't have familial hyperlipidemia. It's from your diet, so you can't just get it right now. But I hear that kind of going around, oh, it's all genetic. And no, it's environment that changed it. But so the girl who this all started from was 3 years old and had coronary disease at age 3. So the thinking is, if you have this process going on for 3 years, and it was clinically significant coronary disease in this 3-year-old. Can you imagine? I mean, then they cloned the LDL receptor. LDL was high, and everyone glommed onto cholesterol. Equally as plausible, there's a hypercoagulable problem, a pro-inflammatory problem in the same disease cluster of problems, and it might not be the LDL itself. So, but LDL has been the focus. And so in these lean mass hyperresponders, you follow them over a year, and they'll get another coronary calcium score to see if they develop any sort of narrowing inside the arteries. Great study. You know, you don't need to be in this study. You can get these things measured on your own. The ultrasound that I mentioned, the coronary score that I mentioned, or you might twist the doctor's arm to get you the coronary CTangiogram, which actually looks in there. If you don't have arterial disease, it makes no sense to me to be put on a medication or an intervention to reduce atherosclerosis that you don't have. You wouldn't be treated for cancer unless you had tissue diagnosis of cancer. So with that, I don't know, I can't be entirely reassuring for everyone. You know, there may be some people who don't respond the same way. The clinic view that I have is that there is not a epidemic of heart disease in people, whether their cholesterol is high or not. If anything, these things get better. I've had people with heart disease who have recurrent issues and get stents even though they're on a keto diet and they've lost weight. So I think that it's more complicated than diet alone. And diabetes, the insulin resistance, the smoking, BMI, high blood pressure, abdominal circumference, the metabolic syndrome, these are all the things that are more important than looking at a cholesterol level. And if you're looking at that lipid subfractions, you want to have the higher LDL size and the LPIR as low as you can. That's the summary of the NMR lipoprofile, the factors that have to do with metabolic syndrome. And in the Debunking paper 2021 that was predicting first events in women, first heart attacks in women, it was that LPIR and diabetes, presence of type 2 diabetes, that were the major risk factors, like 5-fold over every other risk factor that was there. Well, so I hope that clarifies things. I'm going to try opening the chat room, and let's see. All right. So thanks for spending time in the summer evening. You know anything about ketogenic diet in animals? Well, cats are carnivores. Yeah, they do much better with the meat. So do dogs, but they're not obligate carnivores. And it reverses diabetes. In fact, there was a study. We were scooped by the veterinarians. We were doing our diabetes study published in 2008 on humans, and there was one published cheekily in the headlines. It was called "The Catkins Diet in Cats Reverses Type 2 Diabetes," because they made a pun on the Atkins diet, but it was in cats. So actually it can reverse diabetes in cats with a research publication that shows that. Deborah says, had the statin discussion again. Yeah, high from oatmeal, Texas. Well, that, not low carb. Can you move to steak, Texas, D? Or I don't know if that. Hi, Marilyn. My doctor asked me not to come back to her if I won't take a statin. Well, that's pretty forceful. Maybe go back and have that comment or discussion about cancer and giving someone a cancer drug if you didn't have cancer. Let's see, John says a great addition to the AILA course would be a coaching course to help their family and friends and what we're learning. Yeah, it's on the list, but not actively being done. Jessica says, why do doctors that have patients with type 2 diabetes recommend statins no matter what your labs are? Oh, yeah. So Jessica, there's the reason for that, because remember the risk of heart disease is so high among type 2 diabetics, people with type 2 diabetes, that giving medication to lower the heart disease was thought to be a good thing. And, everyone knows giving statins reduces heart disease, and eating low-fat diets could reduce heart attacks. Well, I'm being sarcastic. But everyone knows I think there actually have been studies comparing heart attack events with those of diabetes with and without statins, and the effect is small. But, if that's all you have, you're going to try to build up all of your small effects. Of course, the elephant in the room is, why don't you do something to reverse the type 2 diabetes? And then you don't have diabetes anymore. You don't need to be on the statin because you're on the statin because you have diabetes. So, because we train doctors to use medications, I'm afraid. John says, doctors treating type 2 often don't know that there's a good chance of reversing the diabetes. Yeah, they just don't know. Jessica says, my ratio went from 6.05% to 2.76. So which ratio? I think the best one is the triglyceride HDL ratio, but you could also use a LDL, HDL. There are different ratios that have been used. Let's see, all medical professionals need to be retrained to understand optimizing metabolic health. Yeah, definitely. Particularly those involved in treating patients with non-infectious disease. Yeah. Are coaching courses available for doctors? No, but there are places to learn more about this. The Nutrition Network in South Africa has a training course, and I hope to be able to do one day. Yeah, triglyceride HDL, Jessica, got it. Yeah, that's the ratio to look at. How about giving a cancer patient a medication that has a well-known risk of causing hypothyroidism and all they rely on is the TSH? Yeah, well, okay, good point. Are you planning a book suggest end your cancer diet confusion with Amy and Dr. Kessling? Fantastic course. Oh, thanks. Dr. Kessling did the cancer course for Ayla, and I met her at one of the ADAPT events we did, and I thought the course was super. That's a great thought. Christy, as far as I know, is not a writer to write a book, but Amy could partner. Okay, great idea. Let's see. Kim asks, are false positives a concern with Lifeline Screening? I thought I read something about that. No, well, Kim, I don't know if you're in the medical world or not, but you try it. You'll go and someone will go like this, and you can look over on the screen to see the if there's any sort of concern, then you'd want to follow it up with one done at the hospital. So there are different machines, sure, and so it's designed as a screening test, not as the definitive test. But a screening test, if a highly sensitive test is negative, then that's great. So yeah, if it looks like you have it, then you want to follow it up. But if it says you don't have it, that's a great, reliable test. Which is more important, the calcium score or the lipid? It's a different measurement. I don't know what's more important. I suppose you see, the reason I talk about them is in some areas you can't get the CAT scan score. The doctors won't order it for you, so you have to go through the medical system. The doc won't approve of either. Yeah, well, you can get your own ultrasound. Maybe one day, like happening in other areas, you can talk to a doctor through the internet, and they'll order it for you for a fee. Actually, I think Dr. Tro is helping you get CGMs as the doctor on record, but he has a army of doctors who are licensed in all the different states. So I don't know what's more important. September is when Lifeline will be in my area. Yeah, well, that's reasonable. What about LP(a)? Yeah, well, LP(a) is just another in the weeds cholesterol issue. And, it's not going to be a big factor compared to all the other factors, the diabetes, insulin resistance, the smoking, the inactivity. So, all these other lifestyle factors are more important. Now, if all you had was a drug to treat cholesterol and you think that's all there is, then you're going to focus on that and try to browbeat you into doing it, when changing your lifestyle is actually a potent intervention. So building on Dr. Kessling's short labs for cancer workshop, which was excellent. So just a course on understanding your labs for metabolic health, and maybe a book, and your labs confusion. Yeah, that's a good idea. I think Ken Berry and Kim Howerton did a book on that. Honestly, I haven't read it, haven't looked at it. So that might be a place to start. But yeah, great ideas. Let's see, JJ says, so to clarify, the doctor recommends a statin. You're recommending a calcium coronary score and echocardiogram. Or if you have a coronary calcium score of 0, do you recommend ultrasound? Well, so I think the ultrasound of the neck and the aorta are something that you should get, just as it's your body. And if you want to know if you have vascular disease, it's your right to know. No one should stop you from getting that. And there's a company now that will do it for you. The CAT scans are, again, in the sphere because they have to get they're a controlled kind of machine. You have to have approval to have one. It's in the medical world. You have to get an order to do it because of the X-ray, the risk that there is there. I guess what I was trying to say is get what you can. If you can get the CAC score and the Lifeline Screening ultrasounds, or ultrasound however you can, that would be my recommendation if you're worried about it. Now, I'm not all that worried about it, although I've had my own Lifeline Screening and calcium score. So I'm just kind of curious, but I wasn't going to do anything different based on what I had found. So so JJ, I guess you're in the context that if you had a high cholesterol and your doctor recommended a statin, then you can ask the question of yourself, if your doctor won't ask it as well, do I have the disease that you're trying to prevent? Now, you could come back and rightly so say, well, maybe even if I don't have the disease, this treatment will prevent me from getting it. Well, again, if you're 60 years old and you haven't had any evidence of the disease yet, chances are you're not going to be getting the disease, although you don't have to take the chance. You can measure it. So rather than take the, guideline cholesterol as a disease point of view and take medicine regardless of what you're eating and what your weight is and what your diabetes, score, this is just getting information to help inform you. So should doctors be prescribing statins and blood pressure tablets if they don't know how to treat metabolic health with low carb? For patients, if they don't know about the latter, be very cautious. Yeah, well, so that's like saying, everyone's going that way, but they need to go this way. The inertia of doctors using medication is just so hard to change. They're treating lifestyle with pills, basically, treating bad food with medication. Now, if you've been in the Western world and you have arterial disease, I'm not sure that, changing to a low carb or a keto lifestyle will protect you forever. I don't know that for certain. So you have to go into this eyes wide open. Measuring things, I think, is a great way to do it. Or let's follow the coronary artery calcium, the angiogram study that Dave Feldman is running. If there are 100 people who have super high LDLs and are doing a keto diet and they have no progression of disease, I'd like to see that study be continued every year. I think Dave's going to ask for money every year. And I've contributed to the first GoFundMe. And if there's another one that comes out, of course, I'll let you know about it. Because the longer you can follow those people, and you're sure that they're in ketosis and they then have or don't have evidence of disease on the coronary arteries, that's going to be really good information on a large number of people. That still doesn't tell you what's happening for you, though. Let's see. Angelica says, incredible talk. You're welcome. I read in End Your Carb Confusion about the massive reduction in HSCRP in one of the featured profiles and impact on arthritis. Yeah. It's anti-inflammatory to not eat pro-inflammatory foods. And then ketones actually themselves have an anti-inflammatory effect. So you probably want some ketones around at least some of the time. You brought up pro-inflammatory markers tonight, really interested in the context of the arteries. Would this be a relevant lab in the context of pro-inflammatories that might contribute to disease? Yeah, well, Angelica, it's not quite so simple. These inflammatory markers, the CRP probably being the most commonly used, are pretty easy to go up and down, kind of hard to measure. And I don't clinically actually measure those things because other people have done that in their studies. And it doesn't tell, or I'm not quite sure what to do if you say you're doing keto, you're at your goal, and everything looks good, but you have a little pro-inflammatory marker. I don't know that giving you a supplement for it or having you change something is going to be worth doing. You can see I'm more of that's a big picture mosaic rather than, one tile is off. We got to fix, So in fact, some of the economies that we'll probably find out happens from being in a ketosis may be that to change some of these inflammatory markers in ways that we don't yet understand. And if we assume that we should have markers be the same levels as, let's say, people who eat carbs, that's probably not a good assumption. So, let's stay tuned. And the following the research is key. And thankfully, there's more research being done. So let's see, after 3 months of keto, I'm 32. My HDL has gone up, triglycerides lowered, while LDL has risen to 280. So this is super interesting. Yeah. So not to worry too much. Okay. And, if you were wanting me to say, don't worry at all, go to Ken Berry. He's going to be way out here and say things that, I can't say. I need some studies, some, published science to support the things that I say. That's just my position in this whole kind of keto sphere. Let's see. Christina says, great takeaway. High cholesterol is not a disease. Yeah. I'm getting my husband to try to drop his Lipitor, but he won't. Well, yeah. You may need to have a different doctor or an influencer or he said, once you're on it, you can't stop it. No, that's not true. No, not at all. Common Sense Labs by Ken Berry is the book he did with Kim Howard. Lynn says The Great Cholesterol Myth by Johnny Bowden and Dr. Steven Sinatra. Yeah, that's a good one. Dr. Sinatra is a cardiologist, and Johnny Bowden has been in this area writing books for decades. I mean, I got into this in about the year 2000 or 1998, and he had already been writing books about different low-carb diets. My radiologist said no calcium score because of high radiation. Well, it's about the same amount as a mammogram. So, or you could argue the air travel thing. Well, it's like going on an international flight. So now some doctors and me too, if you don't need radiation, you don't want it. I have a family history, one of these terrible stories. But it might overestimate or overinflate the risk for me. But one of my grandfathers was a dentist, and they were using x-rays before there was any shielding, and it developed a bone cancer called multiple myeloma. And so you don't want to take the radiation cavalierly. So you have to balance the risk of any test we do with the benefit. If you're worrying all day long about this thing and getting a test will relieve worry, it's amazing. Some people you can feel perfectly well physically. And then this one little number, because the doctor yells at you because of this number, now suddenly you're racked with fear and mentally you're now off. Please don't have that sort of effect. Suggest investigating the book, The Glucose Goddess, and the method she used to test her recipes crowd-like. The author is a French-based biochemist, published 22. I'll check that out. Thank you. Kathy says, I'm in Canada. It's hard to get referrals for these tests unless the doctor feels they're necessary. Well, okay. Well, then, try convincing the doctor, with some of the arguments that I've used tonight may do it. How do you know I have the disease? Well, did you, are you going to put me on a medicine for a disease I don't have and might never get? Well, I don't, they might say, well, that's the guideline. Well, you have to, think beyond the guideline, doctor, right? Actually, there are times when leeches were the guidelines. Doctors were using leeches. Now, the irony about that is that in leeches, that venom, there's an anticoagulant, and it might have actually had some benefit, because in some conditions, taking an anticoagulant might actually be helpful. So anyway, that's just, so the irony is that we think we know the answer, and then time passes, and even in medicine, which should be, as scientific as you can, that it's a human endeavor. So Angelica says, I'll look into the tests, Lifeline Screening, great. Where do we find information about low-carb diets, like low-carb Denver? Glenda asks. I'm not on Facebook. Kim, thanks. Lowcarbevents.com has some events. The next one, kind of in my sphere of going to, which I'm not going to next month, I can't make it, is Low Carb San Diego. Of course, they've changed the name now to the Society or Symposium for Metabolic Health, but that's a good one if you're on the West Coast. That group has another meeting in Boca Raton next January if you're on the East Coast. And those are great combinations of science and people's experiences. And these are CME levels, so that may not be appropriate if you really don't understand, if you can't get into the weeds with a lot of this. Low Carb Denver this year was pretty outstanding. It had people who hadn't been in that kind of area before. So Jeff Gerber, who runs that meeting, a friend of mine, worked hard to get people kind of outside the usual echo chamber to come. And so, yeah, that's a good one to have on your radar. Now, there are like smaller meetings around the country that are geared more toward having fun and fellowship. There's one in Louisville, one in Orlando. And so if traveling is a problem, you can even find ones that are closer to you. Salt Lake, the Keto Chow folks put on Keto Salt Lake. That's a good meeting too, if you're up in that area. Well, so does anyone, I just want to have any specific labs. I want to show just one website. It's the Mayo Clinic Statin Decision Aid site. So you go there, and I'll pull it up in just a moment. You have to know your lab tests and a few biometric measures. I'll show you in just a moment. And here is the Mayo Clinic Statin Choice Decision Aid. And have you heard of the Mayo Clinic? The Duke of the North, of the Midwest. So what you do, if you, let's say, okay, I'm not quite sure I trust Dr. Westman. It's okay. We're as I mentioned before, 25 years ago, it's like I'm on the boat that Christopher Columbus is on, and we're headed out from Spain. And I got totally the classic teaching from our era, our small. So discover the new world, and everyone said he was going to fall off the end of the world. Well, I'm on that boat with you. So, I'm looking out on the crow's nest to make sure if the end of the world comes, we're going to turn this boat around, right? So it's just the other day in a local seafood establishment. I'm in there having some tuna bites, having fun with black tuna bites this summer. And there's a picture on the wall. I wish I could put it on the screen for you. It's a painting of Christopher Columbus and the Nina Pinta Santa Maria falling off the edge of the world, as if the edge of the world did come. And, going on a low-carb diet actually did kill everybody. So that was, I took a picture, and I have to work that into some talks, because I'm thinking that we haven't found the edge of the world yet. And there was this great painting that basically, said, the Columbus trip, it didn't end up so well. Anyway, that was kind of funny, because I don't think we found the end of the world. I can't say we found the magic kingdom or whatever, the spice trade and India trade route, whatever he was looking for. But anyway, so back to the statin decision aid choice. this is a choice decision A. So you go in here now. Can you see this? Okay, just a quick thumbs up. It's a little small. Yeah. Well, if you go to the website, you can make it bigger. What you do is, let's say, great, thank you, Kim. Do you have a history of events? So I click on the ACC, AHA. This is just one of the several guidelines. Do you have a history of prior heart attack or stroke? No. These figures are used to calculate my risk in the next 10 years, okay? And it's a heart attack risk. So I'm going to put in, let's say you're 70 years old, you're a male, and you're white, you're not a smoker, you don't have diabetes, you don't have high blood pressure, let's say your blood pressure is good, it's 120/80, so they only ask for systolic. Let's say your HDL is, on the good side, maybe 70, and then your total cholesterol, well, let's say it's the highest you can, and the maximum there is 350. I don't think 351 is allowed. Yeah, the red thing comes up. So let's say it's 350. So your current risk with all of these parameters for 100 people like you who don't have medication would be 19 out of 81 will have a heart attack over the next 10 years. Remember, you're 70. So this is going to be probably a time when you might consider taking a pill. Well, let's see what happens. So select an intervention. And let's say you're on a statin standard, let's say high dose. Well, it didn't let me do it. So let's say you take the statin pill. This shows you, so the green means you don't have a heart attack. The yellow means you do get the heart attack. And the blue on the right one is the reduction in heart attacks that you would get based on the pill. So if you took 100 people with your risk and you would go from 81 people won't have a heart attack to 86 won't have a heart attack. So it doesn't make it zero, right? But it reduces it. Now, if you look at it the other way, on the left-hand side, you have a 19 out of 100 risk. You take a pill for 10 years. On the right-hand side, the risk goes down 6% to 14%. So basically, you're manipulating the yellows, reducing the number of people who have events. Now, if you're, an optimistic guy like me, and say, well, I'm one of those green people, I'm probably not going to have a problem. And of course, you don't know, but getting a coronary score, carotid artery is going to make you more informed. So you might say, well, gosh, I only really go from 81 to adding on 6, so 86 out of 100, so that's not a big change. Of course, if you're one of the ones who didn't have the heart attack, you're really happy about that. But this is why it's so muddy, and so why doctors just say do it. Well, let's do another risk. Let's say you're 70, you're female. Let's just see how that changes things. So just going from male to female and put the risk in there, you basically go down to a 9 out of 100 risks. So being male is an important factor there. But if you went on a statin, 2 out of the 100 will be saved. Your risk is reduced by this much, from 9 out of 100 to 7 out of 100. Now, if you're someone who, I'm worried about it, I want to do everything I can to reduce my risk, you're not having any side effects from the drugs, you might want to take one. Of course, this is following carb eaters. I think if you don't eat carbs, you're probably going to have less risk, but that's just, my judgment call. So now let's take someone who's had heart disease. Now, what it's going to do is going to take us out. So this calculator should only be used for primary prevention. So it's kind of making the assumption that if you've had a heart attack, you should be on the statin. It's not, so it's like they decided we're not going to help people not take a statin if it's for secondary prevention. They want everyone to take one, basically. That's my thinking there. But let's say you're 50 years old now, let's see, there are a couple chats. Okay, did anyone put in your number? Yeah, no. So is your risk only reduced by 2 to 4%? Why would you take a statin and risk all the side? Well, that's up to you. some people are not informed. You only get informed about the good, not the bad. And so let's see, let's say you were 60 and male, generally it would be higher risk. Let's say you're a smoker, you have diabetes, and you're, okay, no one's smoking, right? No, these days, take away the smoking. Let's say you have diabetes, treated high blood pressure, but your blood pressure is normal. Let's say your HDL is not so great. Let's say it's 35. Let's say your total cholesterol, is okay. Let's say 250. So you can actually go in and manipulate the numbers and see how the risk changes. And now this risk here is a lot higher because of the diabetes and the blood pressure. 25 out of 100 people will have a problem over the next 10 years. And then if you take a high dose statin, for example, just changing that intervention here, you go from 25 having a heart attack to 15 having a heart attack. So 10 out of 100 will be saved. That means, 1 out of 10 times you get benefit from the pill. So you can see once you get into the medical disease, this person has diabetes, probably will always have diabetes because in these cohorts, nobody reversed their diabetes. There was no Ozempic or Mounjaro or that's actually helping people now reverse diabetes just by dint of the medicine causing weight loss. So there are going to be more diabetes reversals by drugs happening. But again, that's not the only way to do it, right? So go to statin choice decision. I do this in, time, if time permitting, with people to coach you how to use this with your doctor. So if let's say the risk is low again, let's say your HDL is I had someone who came in their HDL was 100, and I was like, gosh, Tony, don't worry about anything. I mean, from the blood standpoint, that's amazing. So let's say you're female, you're 70, but you have an HDL of 100. Let's see what the current risk is. Well, it's only 8 out of 100, and then high dose statin would reduce that by 3%. So now just a little bit about we're talking about absolute risk. When you talk about relative risk, it gets a little slimy, where here you could say that 8 out of 100, 8% have a heart attack. Here, 3% out of 100, 5 have 100. So you reduced it by 3. Well, actually, so you reduced it by 3 out of 8. So it's like a 30% reduction. Relative risk reduction. Be careful, as someone says relative risk reduction, it's not the absolute risk reduction. And that's David Diamond at the University of South Florida, Tampa, has written many papers about this, how the companies and gives presentations, how they've oversold and kind of fraudulently said their medicines work better than they do because they've always focused on relative risk reduction. And it is more persuasive to hear that your risk goes down 30%. Well, actually, it goes down 3% absolute risk, but 30% relative risk. Let's see. And one last, when do you recommend blood pressure should be measured? John, when the ambulatory care blood pressure meters came out, this was, I was in training at the time. What you're going to learn is that the blood pressure goes up and down over the course of the day. So this is a machine that just goes on and off automatically. And the correlation of optimal time to take it with risk, I don't really know. You just want to be sitting, putting your arm at the level of a chair, about your heart level, and relaxed after 3 minutes or so to check the blood pressure. I think you'd want to have it in a good range all day long. If it's going to go up when you're exercising, and even then, I learned recently that the normal blood pressure of a giraffe is 250 because they're so tall. It takes 250 millimeters of mercury to get up to the height of a giraffe. So if you're taller, you're probably going to have a little higher blood pressure. It's going to be okay. But, I would say, I think most people recommend just vary the times, and write it down, keep a record. And then that's what I do. And then I just review it quickly in the office. Well, so this is Mayo Clinic Decision Aid was kind of a find, if you will, to help you personalize your own decision making. And you're asking all the right questions about why would someone do it for that. I think the reasons are, well, doctors think there's nothing else that they can do. Guidelines kind of tell them to push medicines. And I think actually a doctor will have a requirement that people with diabetes are on a statin, like we talked about today. And so if you'll get kind of a nasty gram as the doctor if someone's not on a statin with diabetes, but if you're reversing the diabetes, and then you can get off the diabetes medicines and then off the statin medicines that were being used to treat also the kidney protection medicine for diabetes. You can get off that as well because you've reversed the diabetes. Well, thanks for hanging in there. I wanted to get through some didactic stuff and then answer questions. Again, it's my pleasure and really honor to be able to help you and in a way that I had no idea that we'd be able to do this for so many people in so many different places. The Adapt to Your Life YouTube channel just went through the 100,000 subscriber level, and that's a milestone for YouTube channels. And so they send you a silver or award, and so I'll be opening that, and it's not that there are 100,000 active people, but so sometimes the reach is even greater than that. And I'm teaching more people now through the internet just because of the power of scaling this and getting it to you than I am in the office. But there's a role for me to help people get off medications. There's a role, apparently, because recently someone wanted to come in and just go over that statin aid, personally, and to be able to chat with somebody. And someone recently wanted to come to just see if I was real. So Tuesday through Friday, I'm at Duke. You can make an appointment if you want, and it might be a while to get in, or if you call if you're flexible with your time, you may find there's a cancellation the next day and you can work your way in. So, but it's really fun to see and teach, have more and more people coming in, learning. Even now, undergraduates have kind of gotten the message. So there is a Duke undergrad and an undergrad from Michigan State who's learning and getting the younger mind open to this is just such a great thing. If you know Laura and Matt, who are doctors who are in Winston-Salem, they just had a keto baby, 1 month old, and they've shadowed me in my clinic. And they're going to be the new generation of doctors. It's really exciting to see that. So, again, my pleasure. Thanks for staying up or on the replay. Thanks for watching. Bye-bye. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell. And check out adaptyourlifeacademy.com.